liver-related obesity. Go ahead, Eric.
All right. Good evening, everyone. So title of my talk this evening, and thank you for the introduction. Title of my talk this evening is Cardiovascular Health Disparities in Metabolic Associated Dysfunction and Fatty Liver Disease. And this is work that I've been doing with Dr. Robert Wong, who's here on the call tonight. I have no disclosures. So I'll start by sharing this dynamic map of the globe. And what we're seeing here is the rising prevalence of a certain condition, starting what this map shows is in the 1970s and moving forward. And if we kind of look back, we can see that most of the world started off with a prevalence less than 10% of this condition. But this has been rapidly rising, especially in developed nations, leading all the way up to where we are today, where a lot of these areas are in the dark red, kind of in the prevalence of greater than 30%. And I'm sure most of you guys, based on the title of my talk, know what I'm talking about. And this, of course, is the problem of obesity, the obesity epidemic. So there is a lot of sequelae of obesity, and one of those, at least within the GI hepatology world, is fatty liver disease. And so now this is a different global map looking at the prevalence of non-alcoholic fatty liver disease, or NAFLD. And so you can see where we are in Northern America. We have a prevalence of about 24%. And this varies based on different regions, you know, as high as 32% in the Middle East to as low as 13.5% in sub-Saharan Africa. And what this heat map kind of shows is daily caloric intake on average. And the reason I point that out is because there is kind of a disconnect, at least in terms of, you know, a number of calories consumed per day on average and actual prevalence numbers of NAFLD, suggesting that there's probably more to the story than simply calories in, calories out. So in terms of the natural history of fatty liver disease, out of every 100 patients, you might have NAFLD. About 5 of those over the ensuing few decades will develop cirrhosis. Another 2 or 3 of that number will then go on to develop decompensated cirrhosis, and only 1 or 2 of those 100 will actually develop or go on to die from a liver-related death cause or need transplant ultimately. So what that means is that 95 out of those 100 individuals don't develop cirrhosis or advanced liver disease and die from another cause. So the most common cause of death within, you know, the fatty liver disease population is actually cardiovascular, similar to the general population. But there's actually an increased burden of cardiovascular disease within this population. So suggesting that NAFLD or fatty liver is a risk factor for cardiovascular disease. And this is something that's been well known for quite some time. So what contributes to cardiovascular disease? Well, of course, we know that cardiometabolic disorders are major drivers of poor cardiac outcomes. And so increasingly over last several decades, we've come to understand that there's a pretty strong relationship between certain metabolic disorders and fatty liver disease. And I think there's a strong idea that insulin resistance is probably playing a key role in the pathogenesis of fatty liver disease. And so what I have here on the left is the criteria for the metabolic syndrome, which I'm sure we're all somewhat familiar with. Kind of the hallmarks being high waist circumference, triglycerides, a low HDL, or an elevated blood pressure or fasting serum glucose. And having 3 out of these 5 features would meet criteria for metabolic syndrome. And on the right here is kind of a proposed diagram of the or I guess even tried kind of directional relationship between, you know, features of the metabolic syndrome and adiposity, and in particular visceral adiposity, and then fatty liver disease here. And there are a number of endocrine, cellular, and molecular pathways that have been proposed that we think are all driving the pathogenesis of fatty liver disease and progression towards advanced liver disease. So Dr. Wong and I are both interested in understanding this further. And so we are looking into this new kind of proposed criteria called Metabolic Dysfunction Associated Fatty Liver Disease, or Mafulde, which is what I'll be calling it for going forward. So this is a recently proposed nomenclature from an international panel that seeks to more comprehensively capture the cardiometabolic diseases that are associated with fatty liver disease, and that may also promote the progression to advanced liver disease, such as fibrosis, cirrhosis, or HCC. And this definition is different from NAFLD that I talked about earlier, in that concomitant other liver diseases do not exclude someone from having MAFLD. So if you have heavy alcohol use or perhaps like a viral hepatitis, that would not exclude you from still meeting that criteria. So it captures a much larger number of individuals. So what is the criteria for MAFLD? So this is the proposed criteria here. And so in all individuals, there has to be some underlying diagnosis of hepatic steatosis, which is what we see on the top. Now, this can be detected either by imaging techniques, by biopsy and liver histology, or by serum biomarkers, which is the way we determine or suspect, many patients of having this. And then an individual has to have one of three different things. So if an individual is overweight or obese, meaning a BMI greater than 25 or BMI greater than 23 in Asians, then that would meet criteria for having MAFLD. Alternatively, if there's the presence of type 2 diabetes, then that would also meet criteria for MAFLD. And lastly, if an individual has a normal BMI, so less than 25, then if they have two of these metabolic abnormalities, then they would also meet criteria for MAFLD. And what you can see here, of course, with these metabolic abnormalities, that there's a pretty high overlap with the metabolic syndrome, which is why I showed that earlier. So waist circumference, blood pressure, triglycerides, HDL, prediabetes, and then a couple additional add-ons would be an elevated insulin level or an elevated CRP. So our research aims have been to look at the overall incidence of cardiovascular disease among adults with MAFLD, with a specific focus on potential disparities in cardiovascular disease stratified kind of by different demographics. And for this research aim, we've been using NHANES. And so I'll be talking mostly about this first research aim today, just kind of in the interest of time. And then our second research aim that I'll just quickly touch on is looking, trying to better understand MAFLD within other databases and other populations. And so we're building a MAFLD cohort at the VA right now. And we're looking at the prevalence and predictors of MAFLD within this population, and as well as the rates of advanced liver disease. So now moving back to the first research aim. So this work has been done through the National Health and Nutrition Examination Survey, also called NHANES. This is a cross-sectional stratified sample of the US population that enrolls about 5,000 persons each year. Some of our prior work with Dr. Wong has examined the prevalence and trend of MAFLD from the 2011 to 2018 NHANES. And he found that the prevalence of MAFLD over this time period was as high as 34.8%, which is quite a bit higher than the kind of estimated NAFLD prevalence of around 25%, at least in North America. So our methods here was first to create a definition for MAFLD within the NHANES database to define these individuals. And within NHANES, we used our score to determine hepatic steatosis was the fatty liver index. And the components here include BMI, waist circumference, and then serum GGT and serum triglycerides. So what we've been looking at is the proportion of MAFLD adults that are achieving blood glucose targets, and this is done by A1C, blood pressure targets, and then lastly, ASCVD risk targets. We've stratified these results by demographics that you can see here. We looked at the same time interval from 2011 to 2018 and actually broke this down into 2 time periods to see if there's been any change over time. We've also performed a number of logistic regression modeling to better understand what may be driving the differences. So I'll start here, and I'm mostly just going to be presenting the overall prevalence data here from 2011 to 2018, just in the interest of time, because there's a lot of data to go through. And so here, this is looking at Mafulde demographics. We already, like I said before, there's about 35% of the NHANES meets criteria for Mafulde. You can see that there's a skew towards males greater than females within this population. I'll also point out that Hispanics are overrepresented. And this is something that we've seen in prior studies as well. And then lastly, I just wanted to point out that, again, individuals who have normal BMI or just are simply overweight are also, there's a high amount of individuals who have Mafulde there. And then, of course, high rates of coexistent diabetes and hypertension, which makes sense. So looking at the first target, which is hemoglobin A1C, which of course is a marker of 3-month blood sugar, we can see that within the overall Mafulde population, about 82% of those individuals actually met this goal of 7.0. We kind of chose this goal a little bit arbitrarily, and we're looking at other A1C targets, but 7 kind of puts you right in the range of clearly having diabetes. And just wanted to point out that there are some differences by race and ethnicity. In African Americans and Asians, there's a slightly lower rate of meeting this A1C target goal. And then with increasing age, there's also a lower rate of meeting this goal. We see a similar phenomenon in blood pressure, but so blood pressure goal here is 130 over 80, a systolic of 130 and diastolic of 80. And this is kind of the cutoff for being hypertensive or not. And of course, you can see here that the percent of Mafulde individuals meeting this blood pressure goal is quite a bit lower, less than 50%. And again, that there are some differences with African Americans being particularly low relative to the overall percent, and then a decrease with age. So A1C and blood pressure are great, but only capture kind of one component of cardiovascular disease and metabolic health. And so there's a score that has been developed, and this was a big work that was published in 2013 by the American Heart Association, and it's been very well validated. So this is the Atherosclerotic Cardiovascular Disease Risk Score, also called ASCVD. And this is the 10-year risk of an individual to have a major event like a heart attack, a stroke, or peripheral arterial disease. Those are all to be considered defining events. And I'm sure you guys all remember this from your IM residency, primary care, kind of plugging in a number of different numbers and figuring out, what is my patient's risk? And this is kind of important because it determines whether or not a person should be on a statin, as well as if they should have, really rigorous lifestyle modifications. So I'm not going to go through this whole thing here, but what I'll show is just this component as basically you can break down someone's risk into 4 different categories, either low risk, borderline, intermediate, or high risk. And I've kind of labeled these as ASCVD 1, 2, 3, and 4. And for this intermediate risk and high risk groups, generally individuals should go on to a statin because it's been shown, this is a class 1 recommendation, that a statin is going to reduce your risk of having a major cardiovascular event. So we applied this ASCVD model to our Mafulde cohort, and this is basically the result, and this is from NHANES. And so I'll just show that, about close to 50% of patients kind of fall into this a low or indeterminate group, but about 50% of participants also were in this moderate or high group. So a fairly kind of even spread, but this is certainly higher than the general population. And then actually looking into the numbers a little bit more. So here I'm just showing ASCVD 3 and 4, which corresponds with our moderate and high risk group. And what you can see here is that there's about 23% in each group, and that there are differences, particularly seen by sex. And so males are more likely to have a moderate or a high ASCVD relative to females. And that age plays a really large component, especially with a high ASCVD, where individuals 65 and older are very likely to have a high risk ASCVD. I'm just going to skip over this in the interest of time. This is just kind of some of the logistic modeling, but it's relatively intuitive. And so the thing I'd like to focus on here is actually statin use in in our high-risk Mafulde individuals who have elevated ASCVD. And so in our ASCVD 3 and 4 groups, what I have here is the use of statins. And in our moderate group, we see that overall about 40% of those individuals were actually taking a statin, and that there are some differences here that I won't go into, and that in ASCVD group 4, the overall use of statin is about 57%. And so in both of these cases, I think this just really highlights that there's a discrepancy between what an individual with Mafulde's risk is for having a major cardiovascular event compared to how many are actually taking statins appropriately. So this was kind of an interesting finding. So, and I'll skip over this quickly as well. So the second thing I just wanted to quickly talk about is better understanding Mafulde. And so this is something that we're actively working on. It's kind of our next step. So we're building a cohort at the VA. So the VA is a huge healthcare system, the largest in the US, more than 9 million veterans. There's a very high burden of liver and cardiovascular disease, and there's no large prior studies looking at Mafulde within this population. So we're in the process of building a Mafulde cohort right now, and we are using a similar definition. This time we're defining hepatic steatosis using a different scoring system called the Hepatocytosis Index. And the reason for that is we don't have waist circumference and GGT for many individuals, but the same idea applies, and it's a well-validated score. And what we found from our preliminary results, and we're still continuing to refine our cohort, is that among those 9 million individuals, up to 4.3 of them may have Mafulde, and that the prevalence has actually increased drastically from 44% in 2010 up to 63% in 2020. And this is basically illustrating that in 2-year intervals across that time. I'm not going to go into the age kind of breakdown, but you can see overall there's a steady increase. And then just wanted to highlight here the racial ethnic differences in the rise of Mafulde, and to really highlight that there are some discrepancies here and disparities with particularly the American Indian or Alaskan Native and Hispanic populations at the VA being quite a bit higher, having quite a bit higher prevalence of Mafulde. And so this is maybe a particularly vulnerable population. We also looked a little bit at advanced liver disease within our VA Mafulde cohort, and we see that about 5% have advanced fibrosis at the time of diagnosis, and this has now actually increased over the last decade up to 6.4%, and about 1% have cirrhosis at the time of diagnosis as well. And we're looking into this a little bit further. So just very quickly, conclusions and next steps. We see that there's high prevalence of Mafulde within NHANES, and that there are clear racial and ethnic differences. Many individuals are not meeting target goals in terms of blood pressure and serum glucose, as well as many individuals have high risk ASCVD but are not taking statins. And so this is an area that we're looking into further. We also see very high prevalence of Mafulde within the VA, and this is something that we're continuing to flush out. Our next steps for NHANES is to basically write up our findings and potentially look at other surrogates of cardiovascular disease. And then within the VA, we're continuing to refine our cohort and then perform similar analyses looking at cardiometabolic risk factors and target goals. And then the goal ultimately is to identify high-risk patients that have Mafulde who may benefit from clinical interventions in terms of lowering their risk for cardiovascular disease going forward. So with that, I'll give thank you to my primary mentor, Dr. Robert Wong. We have an amazing data analyst at the VA, Zoe, who's been incredibly helpful. And lastly, a few additional research mentors, including Dr. Chung, Dr. Chitnis, and Dr. Ahmed, for their support with this work. So thank you so much for your attention.
Thanks, Aaron. We'll just, we'll leave it to anyone having any questions for the next 2 minutes. I guess I'll start first. I mean, Aaron, I think I may have missed this in one of your slides, but with the A1C 7% target, was it the overall trend increasing from the 2 errors that you calculated? I guess my thought would be like, I guess I would imagine the insulin resistant would be increased on towards the 2 different errors, given that it's one of the underlying kind of most significant pathophysiology reason why people have worsening NAFL and worsening steatosis as well, fibrosis. But yeah.
So looking at, yeah, I mean, I think, so you mean talking about overall trend here from these two time intervals, 2011 and 2015 to 18?
Is this A1C grade? Oh, never mind. It's less.
This is A1C less. Yeah, sorry. This is less than 7. So I think the idea is that things are getting potentially worse. That fewer individuals are actually meeting that goal of having a more restrictive A1C target. And I think this would potentially line up with this idea that metabolic health is worsening in the U.S.
Gotcha. Yeah, sorry. I thought it was greater than 7. So I was like, I wonder why is it going down when fatty liver?
No, it's a good question. Absolutely. Yeah. I mean, it's not a huge change, but I think we do see a slight decrease in meeting that goal. And I think we're interested in looking a little bit further into, actually maybe using the cutoff of diabetes of 6.7, as well as looking at pre-diabetes cutoff, because I'd imagine many individuals may not be meeting necessarily a goal of 7, but are probably falling nicely into that pre-diabetes range greater than 5.7.
For sure. And I guess in your VA cohort, is it a retrospective or a prospective cohort?
The VA cohort is retrospective, but it's the VA database is constantly being updated. So we kind of set our cutoff point as 2021. But so it's pretty up to date, but it's going to be retrospective. Yeah.
Yeah, I'd be interested what you guys continue to find, because I feel like I think the use of statin is definitely under use in our patient population.
Absolutely. Yeah. And I know there's, people even worry, oh, are statins safe in cirrhosis and all these things, and this comes up, and I'm sure, you're interested in this as well. And certainly it's something that needs to be prescribed for many of our patients. And even, even those without cirrhosis, of course. So yeah, well, maybe I'll have the chance to present some of this next year when we have a bit more information.
Maybe when you guys do your cohort, I think they're looking at GLP-1 agonists too, just to see, given that that's one of the main. I think there was a recent study in gastro looking at use of semaglutide as well as diabetic. I think there are studies like semaglutide with diabetes management as well as weight loss. There was like 70% of people who had both of them. Reduce I think greater than 10% weight loss. So
yeah, no, semaglutide's a great medication. Maybe we'll hear a little bit more about that with the NASH talk in a few months. Yeah.
Awesome. Does anyone have any other questions for Aaron? All right, we'll go on to the next speaker. Mike, you want to share your screen?
Yep. Let's see. Okay.
Hi everyone. I have the privilege to introduce a dear friend of mine, Dr. Michael Wei, who I had known maybe since our time with Dr. Mindy's lab. So Dr. Wei completed his medical degree at Wells Cornell Medical College prior to his completing his residency in internal medicine at Stanford. It's currently his 3rd year of GI fellowship at Stanford. His research interests really including colon cancer surveillance, complex polypectomy management, as well as AI application in GI. He's actually starting his advanced endoscopy fellowship at University College Irvine this coming July with a focus in complex polypectomy and bariatric endoscopy. Go ahead, Mike.
All right, thanks, Nghiem. All right, thanks everybody. I'll be presenting on my work in doing a clinical trial on Everlift in polypectomies. So the study is titled Randomized Controlled Trial Investigating Use of Submucosal Injection of Everlift in Rates of Complete Resection of Non-Pedunculated 49 millimeter polyps. This is work that's been done at the VA with multiple of our endoscopists, some of whom are here, including Dr. Kwan, Dr. Wong, and Dr. Pan, who's part of NCSCG, Dr. Louie, and the rest of our pathology team, and lots of our very, very helpful nurses. And so over time, different solutions have been utilized during polypectomy, and so that's including saline, glycerol, glucose solution, methacellulose. These solutions can vary in histopathological integrity, ability to maintain a submucosal cushion, complete resection rate, and cost. Many of you may be familiar during your endoscopic procedures with newer products like ORISE and Eleview. But currently, guidelines recommend removal of colon polyps less than 10 millimeters with a cold snare without need for a submucosal injection. There are actually very few studies, though, evaluating the use of submucosal injection in polyps less than 10 millimeters. And 2 studies to point out: in 2018, Zhang and group compared cold snare polypectomy with or without submucosal injection in the removal of polyps 6 to 9 millimeters in size, and found the incomplete resection rate was significantly lower with compared to without submucosal injection at 1.5% compared to 8.5%. In contrast, though, Shimodate in 2020 compared cold snare polypectomy with or without submucosal injection for polyps 3 to 10 millimeters in size. In this case, their group found no difference in rates of complete muscular mucosal resection. The differences in the results bring up some questions, whether it's related to the size of the polyps in the study, the methodology to determine the complete resection. But in any case, I think overall it suggests that the benefit of submucosal injection for some centimeter polyps is unclear. Could the specific submucosal injection agent actually impact resection rate? So far, nobody's really looked at viscous submucosal lifting agents. And in part, it's probably because of the costs behind the submucosal lifting agents, Elaview and Orize. So in June 2020, Everlift came out, and that's provided by GS Supply and approved by the FDA at the time. And so in our study, we decided to investigate the potential role of Everlift in cold snare polypectomy for polyps 4 to 9 millimeters in size. Specifically, we're interested in understanding whether Everlift submucosal injection improves complete resection of polyps. This is a single-centered prospective randomized clinical trial that took place at the VA Palo Alto, looking at 4 to 9 millimeter polyps, looking at cold snare polypectomy with or without Everlift injection. So patients 18 to 79 years of age undergoing colonoscopy for any indication were recruited between 2020 and 2021. During each colonoscopy, individual polyps that were seen underwent block randomization to removal with or without submucosal injection. What that meant was our research assistant, Dr. Chen, upon encountering a polyp that was deemed okay for the trial, and opaque envelope was open, designated the type of polypectomy. This is the cold snare that we used, which is an X-Acto cold snare. And using this cold snare, when it was open, we were able to determine the polyp size. Description and location of the polyp was recorded at the time of the procedure. A removal of the polyp en bloc or piecemeal was documented. And following polypectomy, when polypectomy was felt to be complete, 2 biopsies were taken from the margins, and these were cold biopsies. Each colonoscopy was video recorded, which allowed us to be able to determine the time of polypectomy. And this was painstakingly involved looking at the time between when the snare was introduced into the screen to when the polyp was completely removed. This also allowed us to verify the number of snare passes to remove all polyp tissue. As mentioned, after endoscopist achieved complete resection, 2 cold biopsies were performed, and this was placed in a separate jar. The rest of the work then went to our VA pathology team, who classified all polyps and evaluated the polyps for residual tissue at the margins. The pathologist was blinded to the method of polypectomy, and so every requisition form that was sent to our pathology team, we redacted the technique of polypectomy. Overall data collected included patient demographics, use of anticoagulation, history of liver disease, polyp size, Paris classification, the ultimate polyp histology polypectomy time, and 30-day complications. In terms of outcomes of interest, so our primary outcome was complete resection rate, which is defined by the absence of residual polyp on those 2 cold forceps biopsies from the polypectomy margins. And a primary outcome was tested for non-inferiority. Secondary outcomes were time to resection, number of snared attempts, and then rates of complications. In terms of the non-inferiority study, so we used some of the work that was done by Papasturgiou, in which cold snare EMR non-pedunculated polyps 6 to 10 millimeters in size achieved complete resection of 92.8% of polypectomies. We used this data and hypothesized that polypectomy following submucosal injection of Everlift could also achieve 92.8% complete resection rate. For polypectomy without submucosal injection of Everlift to be considered non-inferior, we calculated that 115 polyps were needed in each group to achieve an alpha of 0.05, power of 90%, non-inferiority margin of -10%. If the lower bound of the 95% confidence interval is greater than -10%, we were able to conclude non-inferiority between polypectomy with or without Everlift. So in terms of our patient characteristics, we ultimately were able to have 159 patients in the trial. 105 had polyps removed with Everlift, 109 without Everlift, and 55 patients had polyps removed by both with and without Everlift. Patients had similar distribution in age, sex, race, ethnicity, height, weight, BMI, and anticoagulation use. For example, for our age, we had an average age of 68.9 and 68.7 between the two groups. Patients had similar distribution and presence of cirrhosis, very low at 2 to 3%, indication of procedure and sedation. As is the case for most VA patients, most of them underwent conscious sedation. There was similar mean Boston Bowel Prep score and withdrawal time between the two groups. Overall, there were 2 patients that suffered 30-day complications. One patient had a polyp that was removed both by Everlift and also without Everlift. Ultimately was admitted for a splenic infarct at an outside hospital and had splenic artery thrombosis. Well, this was thought to be in the setting of being off Xarelto. Another patient had 3 polyps removed, 2 with Everlift, 1 without Everlift, admitted for tachycardia, thought to have some bleeding, but ultimately this was thought to be related to a 12 millimeter EMR site. So overall, we conclude that none of the patients had complications related to the actual polypectomies performed for our study. In terms of polyp characteristics by intervention, so we had 142 polyps that were removed with Everlift and 149 polyps that were removed without Everlift. Mean polyp size was similar between the two groups, and we had 5.3 millimeters between both groups. Distribution of polyps throughout the colon was pretty similar between the with and without Everlift groups. In terms of pathology, there was a very similar proportion of polyps that had tubular adenoma, so 87.3% in the with Everlift compared to 84.6% in the without Everlift. In terms of the primary outcomes here, there was no significant difference in complete resection between the with and without Everlift injection in 98.6% compared to 97.3%. Overall, the difference was 1.28%, 95% confidence intervals, as low as negative 2.66 to 5.42%. And as the non-inferiority margin was greater than negative 10%, overall, we felt that the non-inferiority marker was met, and so no difference between with compared to without Everlift submucosal injection. Fellows were involved in our studies, and fellows were involved in more polypectomies without Everlift at 16.8% compared to 9.2%. We found that hemostatic clips actually were used a whole lot more frequently in polypectomies with Everlift at 13.4% compared to 3.6%. Mean polypectomy time, as you would expect, was significantly longer with submucosal injection compared to without, at 109.8 seconds compared to 38.8 seconds. And as you know, in order to be able to do a submucosal injection, you have to get the injection needle, you have to inject it, make sure it looks good, take out the needle, and put back the snare. And so that accounted for the significant difference. Overall, there are limited studies available looking at the use of submucosal injection in some centimeter polyps, and none so far looking at non-viscous agents. Given the lack of data available, we performed the first randomized non-inferiority clinical trial looking at resection rate of viscous submucosal injection in sub-centimeter polyps. In our study, we find that submucosal injection of Everlift was not inferior to without injection, but unfortunately didn't offer any clinical benefits. It didn't improve the resection rate of non-pedunculated polyps. Unfortunately, it also was associated with increased polypectomy time, significantly so, as well as use of hemostatic clips. Based on our results, we find that the additional cost and time associated with use of Everlift is probably not justified. Limitations in our study: this was performed at a single center. A multi-center study may possibly have added more diversity to our patient population, but utilizing a randomized clinical trial sought to mitigate patient differences. Proceduralists and pathologists were not blinded to the techniques that were used, but we tried our best to blind them as much as possible. And so our proceduralist had an opaque envelope that was only open at the time of polyp removal, and a pathologist had requisition forms that were redacted. Though, as you can imagine, if you see blue in your polyp resection, then you would expect that that was probably because of Everlift injection. Sizing of polyp, as is the case for many of these studies, may potentially be inaccurate. And there's been multiple studies demonstrating inaccurate measurements when you take the polyps out and you measure it by millimeter size. In this case, we attempt to limit the issue by using the open exacto cold snare as a ruler to best estimate the size of the polyp. So at least there was some standardization that was used. Finally, there's the question of the study being underpowered. But given the high percentage of complete resection that we achieved, over 97% in each arm, extending the trial we don't think would likely change the overall conclusion. So in our first randomized clinical trial looking at this, we find that submucosal injection of Everlift met the non-inferiority criteria for complete resection for polyps 49 millimeters in size, but there were no clinical benefits. Injection unfortunately increased the time needed for polypectomy as well as need for hemostatic clips. And as such, we feel that polypectomy of 49 millimeter polyps can be safely performed without submucosal injection of Everlift. I'd like to thank Dr. Freeland, Dr. Huang, who have been my mentors throughout the program, Dr. Kwon, Dr. Pan, Dr. Wang, who are part of NCSCG, who have been our endoscopists for our study, and Dr. Chen, our research assistant, Dr. Louis, and the rest of the pathology staff, and of course, the VA nurses that have been so helpful and so patient for our study. All right, thank you.
Thanks, Mike, for the awesome presentation. I'll leave it open to questions. I guess I can go first. Hey, Mike, for this study, it's amazing. I think it's an amazing study to complete during fellowship. I think it's a lot of work, especially going through all the videos. But I guess, did you look at sub-analysis in terms of the polyps that are maybe on a larger end, not the 4, not the 5, but maybe towards like the closer to 8 to 9 to 10, as well as the more of a flat, non-polypoid kind of sessile polyps? And was there a difference in those two? Because I feel like using the EMR technique would be beneficial most for those polyps versus like the typical pedunculated or even the nicely sessile 5 millimeter polyp.
Yeah, great question. We actually have just been working on the univariate, the logistic regression of looking at different factors involved important in complete resection. And actually it makes no difference in terms of the Paris classification, size of the polyp, the location of the polyp, use of the clip, whether you do piecemeal resection or not piecemeal resection, made no difference at all. I think the thought is once you're that small and you're using a cold snare, you're probably removing enough tissue that it doesn't really make a huge difference.
Yeah, I'm glad I'm glad your study kind of just supports our kind of routine practice and how our training is. We don't really usually do EMR, especially for subcentimeter polyps. Yep. I mean, the time that you spend on it, and as well as the hemoclip and the resources, the time the patient's under sedation, it's just maybe not worth it. So I'm glad that at least your project was able to prove that. Right. But good practices though. Any other questions, group? All right. I'll have 15 minutes. I can keep my presentation brief. Hey, Mike, do you mind stop sharing? Thanks. Let's see. Share my screen. Hi, everyone. So this is this web project I've been working with our UCSF group. Just a quick introduction. I am currently a third-year GI fellow at UCSF. I'm doing my 4th/T32 year next year, followed by a transplant hepatology year at UCSF in 2023. My interest is, as in front of you, is usually the conjoined factors of obesity as well as sarcopenia, and hopefully the term sarcopenic visceral obesity is something that hopefully can be more used moving forward. So I'll go ahead and start. I have 15 minutes. I'll keep it brief. So I have no financial kind of conflict of interest. This study was possible by these NIH grants. So briefly, sarcopenic obesity is a result of really concurrent loss of skeletal muscle mass as well as gain of adipose tissue, which is reported to be estimated about 20 to 35% of patients with cirrhosis, of which this rate is actually expected to grow, given one, the prevalence of obesity as well as overall aging population cirrhosis. And it's known really the concordance of these two conditions is associated with higher rates of morbidity and mortality seen in both than either of these conditions alone. And this is large. While obesity is really considered a risk factor for poor outcomes in the general population, sort of what Aaron kind of alluded to, the results are really conflicting in patients with cirrhosis, with really some study demonstrating that obesity is a risk factor for post-transplant mortality, while others demonstrating no association. I think this is largely due to the unreliable metrics used to define obesity, which is usually BMI cutoffs, as well as waist circumference. And as we all know, it's really patient with cirrhosis with a dynamic fluid shift, especially ascites as well as lower peripheral edema. The BMI, maybe the waist circumference, may not be the best marker, and especially in cirrhosis when patients are characterized by muscle wasting and cachexia. in some select patient with decompensated cirrhosis, maybe obesity or high BMI is actually a relative marker for health. So clearly, really more reliable metrics of obesity is needed to really help for accurate risk assessments in our patients. So really substantial evidence has really been demonstrating to have the prognostic value of CT scans. Really, CT scan based measure of muscle loss, which is sarcopenia or even adipose tissue distribution. Look at the different depots, the visceral and the subcu fat. And luckily these are patients are usually get the CT scan as part of the HCC surveillance, so it's relatively available. I mean, I think that we wouldn't really recommend using CT scans to measure body composition due to the contrast as well as the radiation, but for patients with CT HCC surveillance, we can use it to really assess for body composition. So we really hypothesized as a combination of CT-based measure of muscles as well as adipose tissue to define this term called sarcopenic visceral obesity could better really identify obesity-related morphometric characteristics associated with post-transplant outcomes. So in our study, we aim to define sarcopenic visceral obesity, and I think that for me, using the 3 different body compositions and understanding that low muscle mass is bad, high visceral fat is bad, given that the visceral adipocity serves more of an endocrine organ that has cytokines, adipokines, myokines that really kind of serves as almost like a inflammatory cascade, as well as subcu fat, which is known to be protective. So maybe assessing these 3 body compositions can better really outline our patients' risks. And we want to examine this association in post-transplant mortality. So we actually conducted in the study really include adult patients with cirrhosis who are non-electively hospitalized, underwent urgent evaluation and liver transplantation within 30 days of listing from January 2005 as well as December 2017. And it actually had abdominal CT within at least 90 days of transplant. The data were playing from 4 centers, UCSF, University of Pittsburgh, University of Alberta, as well as Mayo Clinic at Scottsdale. The patient were excluded if they underwent liver transplantation for fulminant hepatic failure, and the primary outcome was all-cause mortality following liver transplantations. So how we measure body composition, we use secondary analysis, like I kind of mentioned, if in patients who have CT as part of their liver transplant evaluation. VSR, visceral subcutaneous ratio, was calculated using the visceral divided by subcu adipose tissue, which was both normalized by height. And then we measure this at the L3 vertebrae, which has been validated and proven. And then really to identify the optimal cutoff, we first started looking at the relationship between the post-transplant mortality as well as VSR, and we stratified based on sex. So we use a time-dependent receiver operating curve method to really identify the optimal VSR cutoff to predict post-transplant mortality, which is 1.54 for men and 1.37 for women. And then sarcopenia was really defined using AASLD guidelines and cutoff using skeletal muscle index of less than 50 for men and less than 39 for women. So among our 116 patients in our cohort, about 33% were non-sarcopenic, non-visceral obese, 22% were non-sarcopenic and visceral obese, 25% were just sarcopenic without any visceral obesity, and our subjects of interest was about 20% with both sarcopenia and visceral obesity. So these are people who had high visceral fat, low subcu fat, with a higher ratio VSR, as well as meeting the SMI cutoff for sarcopenia. So in this patient population, the baseline demographics are shown. The majority were male, non-Hispanic, white, with a median age of 53, and a BMI of 27.5. There was no statistical significance in terms of age, sex, race, ethnicity, body mass index between the 2 cohorts. And the common etiologies were hepatitis C, followed by alcohol-related, and then followed by autoimmune and non-alcoholic. I think now we did another closer study. I think the NAFL and alcohol related liver disease would be a lot higher. But this cohort was, again, dated back in 2005, 2017. In terms of our comorbidities, rates of hypertension, diabetes were slightly higher in patients with sarcopenic visceral obesity, but not really significant. And the majority had ascites, up to 80%, hepatic encephalopathy up to 63%, with a median male of 32 at transplant. HCC was present in 13% of our patients. So on to the data. So at the median post-transplant follow-up was 67 months. Actually, 29% or 34 patients had died, in which men and women who died had both lower median SMI, higher median visceral adipose tissue, lower median sub-Q, as well as overall high median VSR. None of them were significant though, just trends. Sorry. So as shown in this figure, a patient with sarcopenic visceral obesity had really significant higher cumulative incidence of post-transplant mortality, both at 12 months, 30% versus 8%, and 36 months, 39% versus 13%. And then because of we separate by sex, the presence of sarcopenic visceral obesity did remain significantly associated when we stratify by sex. It was 60% versus 20% in women at 36 months, and then 33% versus 9% in men. In terms of, when looking at the various different body compositions groups, the cumulative incidence of post-transplant mortality was still higher in patients with both sarcopenia and visceral obesity compared to a patient with just sarcopenia without visceral obesity or visceral obesity alone at 12 months and 36 months. When we looked at, in univariate cox regression, only sarcopenic visceral obesity was associated with post-transplant mortality. And in multivariate cox regression, after adjusting for age, sex, diabetes, hepatic encephalopathy, HCC, as well as MELD, sarcopenic visceral obesity still remain significantly associated with post-transplant mortality. And it's kind of like what we talked about earlier. There's multiple studies in the past that have looked at BMI, and this is a term that we probably mentioned. You probably heard of sarcopenic obesity. These studies were looking at just either one BMI greater than 25, which is not really the best cutoff in Caucasians or Asian, and then using the visceral adipose tissue total square area of 100. But then this doesn't really account for different cutoffs, different sex, because there's different quantity measured, and then also the sub-Q component as well. So I just thought, let's evaluate if these two metrics can predict how the sarcopenic visceral obesity metric that we use to predict. So, although the cumulative incidence rate through 36 months was significantly higher in patients with sarcopenic visceral obesity when VSR was defined as, say, visceral adipose tissue greater than 100 centimeters square or BMI 25, there was no real significant difference in terms of mortality rate. And we also looked at, the same model of univariables as well as multivariate cox regression. There was no significant as well. So in conclusion, really, our data demonstrated that the relative distribution of adipose tissue with CT quantified visceral sub-Q ratio rather than the absolute value of its different depot or even anthropometric metrics like BMI or waist circumference or, maybe more comprehensively and objectively defined visceral obesity. Importantly, really the concurrence of the sarcopenic and visceral obesity was associated with worse post-transplant mortality than seen in either condition alone. And our data offers transplant community maybe a tool to assess body composition in both women and men who are acutely ill and whom other metrics of nutritional status or physical function like the liver frailty index maybe not be reliable, especially in patient setting. So just want to acknowledge my primary mentor, Dr. Jennifer Lai, as well as our frailty group, as well as the study coordinators who collect our data, as well as the Qualitative Imaging Processing Center. Of course, the UCSF liver setting, as well as the T32 grant. Yeah, love to take any questions. If not, I can share you our future direction. I think right now, so this is something that we just did to make sure that one, our hypothesis was worth it to actually pursue a larger database study. So we're actually doing a prospective study now looking at the waitlist outcome. So not just post-transplant outcome, but looking at patients with the sarcopenic visceral obesity and whether it affects waitlist dropouts and mortality. And then subsequently, we're hoping to look at maybe changes in skeletal muscle mass, changes in visceral mass, changes in sub-Q mass, depending on their clinical therapies, to see if there's anything that we could augment in the future. But yeah, thanks for the opportunity, guys. Cool. I think that if there's no questions about this, then wish everyone a an early night, and thanks for everyone for coming, and hopefully come for our March talk.